SBAA. SBU is the Spina Bifida Association's new viral education program. Our goal is to bring the world's best care providers and resources directly into your home. SBU is the only free webinar series dedicated solely to the educational, employment, social, self-advocacy, and health needs of people with spina bifida. We hope that you will enjoy today's presentation, Medical Management of Neurogenic Bladder, Birth to Late Childhood, and that you take time to complete the evaluation at the close of the presentation.
Good morning. My name is Elizabeth Yerkes, and I'm a pediatric urologist at Children's Memorial Hospital. I am the director of the urology portion of the Spina Bifida Multidisciplinary Clinic. I'm happy to be able to share with you today our experience in caring for the bladders of children with spina bifida. First slide, please. So again, today we're going to be discussing the medical management of children with neurogenic bladder related to spina bifida, specifically focusing on the newborn period to roughly 10 years of age. There'll be a subsequent spina bifida course, Spina Bifida University course taped on surgical management, and this may be of interest to you as well. So again, today we're going to be talking about medical management of neurogenic bladder from the newborn period to 10 years of age. The challenge for me as a pediatric urologist in caring for children with spina bifida is understanding the bladder and how the bladder may impact the kidneys. And you can see from these pictures that there's a variety of different sizes and shapes of the bladder, and the appearance of them on x-ray sometimes correlates with their behavior. For example, smooth bladders tend to have lower pressures, and the more roughly bladders or irregular bladders tend to have higher pressures, and those are the children I need to be more concerned about in terms of protecting the kidneys. So it's a challenge for me to figure out what each individual child holds. When we talk about neurogenic bladder and spina bifida, of course, we're including several different diagnoses. This would include myelomeningocele, lipomyelomeningocele, other forms of tethered cord, and caudal regression syndrome. And today we'll be focusing primarily on myelomeningocele, but many of the principles of medical management of neurogenic bladder are the same for the other children. So first, let's talk about why we would treat neurogenic bladder, who needs to be treated, when they should be treated, and how. You may have a number of questions, all listed here. I've tried to anticipate those, especially since you won't have the opportunity to ask questions during today's presentation. These will turn up during the presentation, so I won't list each of them separately now. We'll begin with some background and talk about the historical management of neurogenic bladder and how our management today differs from this historical management. We'll discuss how the bladder works in the intact nervous system and also in children with spina bifida. So historically, all individuals with neurogenic bladder were at risk for complete urinary incontinence, and many experienced kidney failure or severe recurrent infections. Many were managed by urinary diversion, such that the urinary stream no longer entered the bladder but was diverted to a pouch on the abdominal wall. This was an artificial form of continence. This is an example of an ileal conduit, one of those forms of urinary diversion. In 1970, Dr. Lapidus introduced the concept of clean intermittent catheterization, and this has revolutionized the management of neurogenic bladder and is still the cornerstone of therapy today. In the 1980s, Dr. McGuire gave us very important knowledge regarding safe pressure thresholds within the bladder, and we know now that 40 centimeters of water is a critical number in terms of safety for the bladder, or safety for the kidneys. Nowadays, we shouldn't have anyone with complete urinary incontinence or kidney failure or severe infections, and we'd like to avoid incontinent urinary diversion if possible. So where are we now? The contemporary goals of management of neurogenic bladder are similar to before in that our number one goal is to protect the kidneys. My second and third goals are also to protect the kidneys, so you can see that this is pretty important. The fourth goal is to help your child achieve social continence while still protecting the kidneys. And the fifth goal is to protect the bladder. As it turns out, the bladder is also sensitive to pressure and reacts unfavorably to that pressure, and actually can become stiff over time, which in turn can impact the kidneys. And finally, the goal is to facilitate independence for your child with their bladder and bowel program. So in contemporary management, there are two different accepted approaches. The first is the traditional conservative approach, which involves radiologic monitoring of the child. If on ultrasound we were to see changes in the kidney, such as hydronephrosis, then we would consider beginning medical management of the bladder. This is an example of a renal ultrasound. In this picture, you'll see that the cursors mark the edges of the kidney, and in the center here is the fat within the kidney, and this is a normal ultrasound. In a child with hydronephrosis, you can see that that same area of fat in the center of the kidney has been separated by dark areas, and that's urine retained within the kidney, or hydronephrosis. And this is a sign that potentially things downstream in the bladder aren't progressing well. So we have two approaches, the conservative management with radiologic monitoring, and another option is proactive management, or urodynamic monitoring, where we watch the children closely and we intervene for hostile findings on the urodynamics, or specialized bladder test, any changes that could suggest that there would be trouble for the kidney or for the bladder in the future. There don't have to be any radiographic changes at the time. So let's talk a little bit about how the bladder and the sphincters work. The bladder essentially has two jobs. The first is to hold urine, and the next is to expel the urine. In infants, there's no voluntary control. The bladder simply fills and contracts and empties. In adults, we gain central control, or control in the brain over the voiding, so that urinating doesn't occur at inopportune times. But in an infant, it's simply by reflex. The role of the sphincters are to hold the urine in and let the urine out. It's pretty simple, but sometimes the sphincter misbehaves. So this is a urologist's conceptualization of how the central nervous system and the bladder interact. This is the brain. This is the spinal cord. And there are several key areas on the spinal cord marked out. T10 to L2 is one center that affects the urinary tract, and then the sacral levels S2, 3, and 4 also have an impact on the urinary tract. This corresponds to the bony levels of T6 and L1 within the spine. To the right side of the screen, we have the bladder, and these stripes are the external urinary sphincter, which is voluntary for adults. And you can see how there's interaction between the sacral spinal cord and contraction of the bladder, and there's a message, the green arrow, that's sent back from the bladder to the sacral spinal cord, so the spinal cord knows what the bladder is experiencing. And finally, the sacral spinal cord sends out messages to the sphincter telling it how to behave as well. The brain is where awareness of bladder filling occurs, and it's the control center for urination in a patient with an intact nerve, or in an individual with an intact nervous system. And the bladder is the site of action. There's involuntary contraction of the bladder muscle with voluntary override, again in an adult with a mature intact nervous system. The bladder neck, so this blue arrow here on the left side, is an involuntary function, and the sphincter, the stripes, is a voluntary function, meaning that we have the ability to control and relax when it's convenient. The voluntary control occurs with time in individuals with an intact nervous system. In individuals with spina bifida or with other nervous system abnormalities, anywhere along the pathway up the spinal cord, that signal can be interrupted. And so even if the bladder is capable of sending a signal to the spinal cord, the signal may not be experienced by the brain, and therefore no response would be sent back down from the brain. So we may have loss of awareness and loss of the function of the control center. And in terms of the bladder, we may have loss of action. So we may get no contraction of the bladder, or we may get a bladder that's functioning independently without any signal from the brain. So each bladder functions differently. So you may be wondering, if you have a newborn, why your child needs so many tests. It seems like you see a million specialists, and there's a different test every day to be had. And that's because every child with spina bifida is quite different, and we can't predict by looking at the child's back what the neurologic impact would be, and specifically the neurologic impact on the bladder. So each newborn would have a baseline kidney and bladder ultrasound, and this is to verify that there's normal anatomy of the kidney, normal structure of the kidney, verify that there's no hydronephrosis, and also get some idea as to whether the bladder may have already been experiencing work. A voiding cystourethrogram is an actual X-ray that's performed by placing a catheter into the bladder and putting some contrast in, and then taking pictures as the bladder is filling and as the child urinates. And this is to assess whether there's any urine going backwards from the bladder to the kidney, because it really should be a one-way street from the kidney to the bladder. If on that study we were to identify reflux, which is present in 20 to 30% of newborns with spina bifida, then the child may be placed on a daily antibiotic to minimize the risk of urinary tract infection. In the newborn period, it's our practice to perform intermittent catheterization while the child is in the period of spinal shock after the back closure. This is an atonic phase or a relaxed phase of bladder function, and the fact that the child is having wet diapers doesn't actually mean that they're urinating. So we recommend that a catheter be placed intermittently to drain the urine from the bladder so that the bladder isn't doing too much work. The goal is to prevent over-distension of the bladder, and once the child is urinating spontaneously on their own, we can discontinue the catheterization. In many cases, the child would go home on catheterization due to incomplete emptying. A baseline urodynamic study is also recommended, and during this talk you'll hear me use the term urodynamics and systometrogram, and these terms are really interchangeable, and what this is a specialized test of bladder function. It can be performed with or without the VCUG, and that's called a video urodynamics, and really what it is a snapshot in time to let me know what the bladder's up to and how that bladder may give me trouble in the future with kidney function, or how that bladder may give me trouble in the future in terms of achieving continence. Ideally, the study should be performed within 3 months after bladder closure, and that's our clinical preference. As I mentioned, it's very difficult to tell what's going on urologically just looking at the defect on the back. I can't tell any more by looking at the back than I can tell by looking at a child's face what's going on in the bladder, and that's the reason for the specialized testing. You should remember that the level of the bony defect in spina bifida does not predict the urologic outcome. It's highly variable. So I need to know what the bladder is doing. The first thing that urodynamics or a systometrogram tells me is the capacity. How much does the bladder hold? The compliance, how stretchy is the bladder wall? Contractions, are the contractions present? Are they abnormally strong or abnormally weak? Or are contractions altogether absent? What is the sensation? How much does the child feel as the bladder is being filled? The sphincter, that's the voluntary sphincter for us. How tight is it? Does it open when the bladder is attempting to empty, or does it remain closed? And we generate a number called a DLPP, or detrusor leak point pressure, which it turns out is very important amongst all these things. The residual volume is the urine left over after the child is urinated. And if we perform this with a video component, we're looking for reflux and for information about the sphincter, and also looking for a picture of the bladder contour that may give us an idea of how hostile the bladder is. As I mentioned, it turns out that the sphincter is actually probably the most important factor here, because if a high-pressure bladder exists and the sphincter is weak, then the urine will come out. But if there's a high-pressure bladder and the sphincter is tight, then we have a very problematic situation. There's some critical numbers that we look for on the urodynamics, and I alluded to this earlier based upon Dr. McGuire's work. The storage pressure in the bladder is very important, as is the outlet resistance or leak point pressure. So we want to know, when does leakage occur? At what pressure does leakage occur? And it turns out that the critical number is 40 centimeters of water. So when we have a sustained pressure above 40 centimeters of water, the kidneys are at risk for deterioration and damage. Part of the most important part of the long-term management of children with spina bifida is the role of the multidisciplinary spina bifida team, and I recognize that many children don't have access to a full multidisciplinary team. This might include neurosurgery, urology, orthopedics, a physiatrist or a physical medicine and rehab specialist, a radiologist, pediatrician, physical and occupational therapists, a social worker, a clinic coordinator, and all the other members of the clinic team. The multidisciplinary spina bifida team is important in that it facilitates communication regarding new concerns for a patient. So if there are 2 or more specialists seeing a child the same day and one picks up on a change, then we're able to move ahead with additional testing more quickly. We have an opportunity to check each other's work, if you will. This allows for earlier intervention. One important thing to remember in the long-term management of children with spina bifida is avoiding exposure to latex-containing products. So include catheters and gloves, bandages, underwear bands, condoms, diaphragms, surgical and anesthetic supplies, potential food allergens such as banana and kiwi, and a full list of precautions and exposures to avoid you can find on the Spina Bifida Association website. The point of latex precautions is to minimize the risk of a true latex allergy due to repeat exposure to the latex antigen. This is a potentially very serious allergic reaction, and if an individual has a true latex allergy, then we need to pre-medicate before any surgical procedures where there could be an exposure to latex. And I would strongly encourage that a medic alert tag be purchased. In terms of long-term radiographic surveillance of the bladder, an ultrasound is recommended on a regular basis. And in my practice for the first year, I perform an ultrasound every 3 to 6 months to follow up on the progress of the kidneys, more to monitor the progress of the bladder. Because if there's a change in the bladder, I'm going to pick it up on the ultrasound. After the first year, I recommend an ultrasound every 6 months for the first 3 years, and then yearly thereafter. This is obviously going to vary somewhat from institution to institution and based upon resources. The recommendations can be tailored based upon the urodynamic risk profile and the child's progress. In terms of urodynamics, in an ideal world, we would obtain this study yearly, and I recognize again that this isn't possible at most centers, and really not practical at our center as well. The study would be performed as a baseline, as we discussed earlier, and then should be obtained at around 3 to 5 years at the expected age of continence for non-affected children. And this is to guide intervention for continence when the family is ready for that. We also would want to perform urodynamics when there was any change in the clinical situation or a change on ultrasound. So let's move on to some of those questions that you might have. So my child is having wet diapers. Isn't that a good sign? Well, it is a good sign because we want the urine to come out. But as I mentioned earlier, it doesn't always mean that the bladder is emptying efficiently. You should keep in mind that only 5% of children with spina bifida will avoid with continence and without any assistance from us in terms of catheterization or medication. So that's a pretty small percent, but I don't want to take away hope from families and tell them that their child won't be one of those 5% to toilet train. But if only 5% will do this on their own, then 95% are going to need some help from this. Keep in mind again that a wet diaper doesn't mean that the child is actually voiding normally, and that a contraction of the bladder or movement of the child or crying may overpower the sphincter and result in a leak. A leak can occur at high or low pressure, and so it's important that we understand what the bladder is doing and whether that leaking is safe to allow to occur. Next question is, when do we really need to get urodynamics in a cystometrogram, or urodynamics or a cystometrogram? Well, indications for a repeat urodynamics test would be new hydronephrosis or progressive hydronephrosis, urinary tract infections, particularly those with fever, any change in continence that can't be explained by a urinary tract infection, any change in the neurologic or orthopedic status, and if we need to track the response to any medical interventions that we've made, such as the addition of a medication to lower the bladder pressures. So if the bladder is safe now, do we have anything to worry about? And unfortunately, the answer here is yes. Bladders can change over time, and that's why we have to watch them over time. So what would the changes be over time? Well, first, when we recover from that spinal shock period after the spine is closed, we go from the atonic or floppy bladder to who knows what, and that's the purpose of the urodynamics test. In addition, the voluntary urinary sphincter that we discussed may experience progressive fibrosis or scarring. The reason for this is that these muscles are only partially innervated. They don't have a normal nerve supply. And so over time, the muscle becomes scarred or replaced by scar, and its tone becomes fixed in place. So it may be fixed open, it may be fixed shut, or it may be somewhere in between. And that is unique to every individual. Like I said, it can change over time. And that has an impact on how easy it will be to obtain continence, and also has an impact on how safe things are for the kidneys. And finally, we mentioned neurologic change. This could be a shunt malfunction, VP shunt malfunction. It could be a change within the spinal cord itself, such as hydromyelia or searing, so fluid collection within the cord. Or it could be in the form of symptomatic tethered cord, perhaps presenting with changes in lower extremity function or presenting with back pain. And clearly we see bladder changes as well with a tethered cord. So just to give you a couple examples, we have a 1-week-old child with myelomeningocele. And you notice how the bladder is elongated in shape, and bladder is here, filled with white. That's the contrast, and elongated and smooth, and we don't see any reflux or urine backing up toward the kidney, and the child actually didn't urinate during the test, so we didn't get a picture of the urethra. The child was clinically seemed to be doing well at home until he experienced a urinary tract infection at around 2 months of age. And so the VCG was repeated, and you can see that there's a big change in how the bladder looks. Remember, we saw a very elongated, smooth bladder before, and now we have a small, irregularly shaped bladder, and these stripes of contrast going up toward the kidney is reflux in the ureters. We also see the urethra on this picture, and the urethra itself appears relatively normal, except there's an abrupt stop at the level of this lower arrow, and that suggests that the sphincter wasn't completely relaxing as the child was attempting to avoid. And this is a very high-pressure, dangerous situation. So this is the result of resolution of spinal shock for this particular child. So in scenario 2, we have a 14-month-old male who had a low lumbar myelomeningocele. Again, remember, the bony level doesn't predict anything about the bladder. He had a urodynamics baseline at 4 months of age that showed that the bladder was small and there were some contractions or squeezing of the bladder. The leak point pressure was safe. There was minimal reflux or urine backing into the kidney, and there was a minimal residual within the bladder. So things appeared safe. He was voiding into the diaper. He had not had any urinary tract infections. And then on routine follow-up, at this 14-month visit, there was new significant hydronephrosis or water within the kidney, suggesting that something's going on now in the bladder. So a video urodynamics test was obtained, and you'll notice there's multiple spikes here on the upper curve, and those are contractions within the bladder, and some of them got quite high, so were different from before. The bladder was small, it had these strong contractions, there was no leakage of urine even at high pressures, and radiographically that sphincter was pinched shut when the bladder was trying to empty. So again, a dangerous situation with lots of urine left behind. So medical intervention was undertaken for this child. We placed him on intermittent catheterization such that the urine was drained from the bladder every few hours, and we placed him on Oxybutynin, which is an anticholinergic medication that we'll discuss further. An MRI was ordered to see if we could identify a source for the presumed neurologic change, and in the interim the child presented with seizures and was diagnosed with a shunt malfunction. He had his shunt revised and the spine improved. This is an X-ray, or excuse me, the MRI of the spine, and you can see within the spinal cord there's dark areas that are consistent with fluid within the spinal cord that shouldn't be there, and that's hydromyelia. Another thing to point out on the right side is that in all children with a history of spina bifida who've had prior spine surgery, the spinal cord will always radiographically appear tethered. So we can't diagnose tethered cord purely based upon the position of the spinal cord on the MRI. But you can see how low-lying it is here, and you can see the cystic areas within the spine extend to the bottom. So after institution of medical therapy and correction of the shunt malfunction, we've had resolution of the hydronephrosis, and the bladder dynamics are much improved. Next question, is there a clear advantage to early medical intervention? That is, what if proactive management is not offered by my team? It's a very good question. Proactive or urodynamic management, remember, is early intervention based upon findings on a urodynamics test. It's not based upon radiographic findings. So intermittent catheterization and anticholinergic therapy would be recommended based upon these changes. Changes such as poor compliance or a stiff bladder wall, or a high leak point pressure, meaning that the urine is not getting out soon enough, or strong contractions with a tight or very active sphincter. These may suggest that the child is at risk for deterioration in the future. Intermittent catheterization is a procedure that no family looks forward to, but is actually generally well tolerated, even by children who have some sensation. It's just a matter of making it part of our daily routine. You can use the brand of your choice. You may choose a regular catheter, you may choose a hydrophilic or a self-lubricating catheter. And it's really just a matter of personal preference. The technique is clean, not sterile. So every time a catheterization is performed, a few bacteria are placed in the bladder, and those bacteria are retrieved the next time, and a few more are deposited. So it's never considered a sterile procedure. Currently, single-use catheters are recommended by the government, and adequate supplies are provided for each individual. I want to emphasize how important lubrication is with catheterization for the long term. We often have children come in and say that they're no longer using lubrication, and I think it's really better for the health of the tissues that they continue to use lubricant even if the catheter will easily pass. There are a variety of anticholinergic medications that are the second part of medical therapy for the bladder, and the purpose of the anticholinergic medication is to reduce the pressures within the bladder and relax the wall, increasing the bladder size while decreasing the pressure and contractility. There are several: oxybutynin, tolterodine, solifenacin, darafenacin, Toviaz, and more to come over the years, and so it's a little bit difficult to keep up, but the principles of all of them are the same. Typical side effects with anticholinergic medications would include dry mouth, flushing and heat retention, blurred vision, aggravation of constipation, which you know is already a problem, and in some cases cognitive and behavioral changes. And when these are seen, they tend to be quite dramatic, and you'll know that you're dealing with a different child and it's time to ask for a different medication. So oxybutynin is historically been the primary drug in management of neurogenic bladder, and again the goal is to relax the bladder wall, to blunt the contractions, make those contractions less strong, and to lower the storage pressure and increase the size of the bladder. It can be administered by oral, intravesical, meaning crushed up and put in through the catheter, a transdermal patch, or now a topical gel. The once daily extended release tablets have been great and exist for the other medications as well, as this results in better compliance with therapy if you only have to take a pill once a day. The side effect profile is also improved with once a day medication because the amount in the system is, the amount of medication in the system is stable throughout the day, and so there aren't any peaks and valleys to result in problematic side effects. Disclaimer number one is that the once daily oral agents, the transdermal agent, and topical delivery are off-label in children, and this applies to a large number of things that we treat children with, as there's not been testing in the pediatric population for a large variety of drugs. So there's no dosing guidelines that have been performed by the pharmaceutical companies. Trials are underway for select agents at this time, and so I'm hopeful that we'll have clearance in the future. Disclaimer number two is that only oral oxybutynin has an indication for treatment of neurogenic bladder. It means that those medications are marketed for a slightly different condition within the bladder, but we often cross over and apply them to individuals with neurogenic bladder. Do we still use these drugs in children? Yes, we do, and we do so with caution. So we'd recommend monitoring for side effects and efficacy, but we're able to use our knowledge of the medications in adults, adapt the dose for children, and achieve good results. So again, proactive medical management objectives are to protect the kidneys and to protect the bladder, identifying high-risk behaviors within the bladder that could be problematic for the bladder or kidneys in the future. The bladder itself is vulnerable to high pressures and can deteriorate over time, and if we can maintain better long-term bladder dynamics, then we can protect the kidneys better, and we can reduce the need for bladder augmentation, potentially. So if we're going to maximize medical therapy, we're going to utilize intermittent catheterization, or CIC. We're going to utilize anticholinergic medications. We may or may not use antibiotic prophylaxis or a low daily dose of antibiotic. This would be used uniquely when the child has reflux or if there's really problematic recurrent infections, but is not typical for all individuals on intermittent catheterization. We may use medications in the class of alpha blockers to help relax the neck of the bladder to let the urine come out more easily, or in select cases we may consider Botox injections to the bladder. So our goal is to stop the end-stage bladder before it can happen. You see here in the upper left the crisscrossing bands within the bladder. This is a picture of us looking into the bladder with a scope, and those bands are actually scar tissue that's built up in between the muscle bundles and results in that irregular contour of the bladder and the little outpouchings that you see here on the x-ray. Those are called trabeculations and cellules. You can see that the bladder on x-ray looks very elongated and irregular, has an appearance similar to a Christmas tree. And you can also see in this case that there's reflux heading up toward the left kidney, and you can also see that the sphincter is tight in this case. This is an interactive picture with the bladder open, and usually the bladder is just a few millimeters thick, but in individuals with the hostile neurogenic bladder, the bladder wall may be as thick as approaching a centimeter. And that's due to the infiltration of scar tissue in the bladder. So if we're looking at conservative versus proactive therapy, is one superior to the other? And actually they're both safe for the kidneys. The key thing is that we have to identify hydronephrosis in a timely fashion, and therefore routine ultrasound is recommended for patients on both the conservative and proactive programs. We have to recognize that clean intermittent catheterization can be difficult for parents of infants, particularly if they're two working parents, and this is due to logistics of having the child catheterized, and if you're not able to have someone else catheterize the child, what that might mean for the family income. So we'd like to think that we are very sophisticated and erudite in our decisions we make about the bladder, but there's a lot about management of neurogenic bladder that's art. in addition to the science. You should keep in mind that there's two different courses that we can take on the road. We can choose conservative or proactive, but the goal for each of them is to avoid this, renal failure. We want to avoid that at all costs. You notice that this is exit only. Next question you have is, when will my child toilet train? Well, whether a child can toilet train or not presumes that there are safe bladder dynamics. If there are unsafe bladder dynamics, then I can't let a child attempt to toilet train on their own. And if you have other children who are unaffected by spina bifida, we have to manage your expectations about toilet training. They will not toilet train along the same time course, and they may toilet train in a different way. They, like I said, 95% will require help from us to empty the bladder and achieve continence. And keep in mind that individuals are just that. They're individual, and so they're different in terms of their interest in becoming continent. They're different in terms of their ability to ambulate and how that may impact their continence. And they're different in terms of their bladder dynamics, the sensation of the bladder being full and knowing that they need to urinate, the squeezing or contractility of the bladder, and the nature of the outlet resistance. Remember, again, only 5% will toilet train without intervention, and therefore 95% need help from me, either in the form of clean intermittent catheterization and or anticholinergics, perhaps an alpha agonist. That's a medication to tighten the bladder neck, such as Sudafed, which is problematic due to access to the medication and potential side effects. And then in individuals who are able to empty to some extent but not completely on their own, we might try the alpha antagonist or alpha blocker to help relax the bladder outlets to let the urine out. We want to consider the child's desire to be dry and the parent's desire for the child to be dry. Consider existing social pressures at school. Consider the family's situation. And then I would encourage you to be patient and see what your child can do and see what the medical interventions can do for your child. Be vigilant. If you and your child would like to achieve continence, then there's things that we can do for you. You shouldn't assume that the child is destined to be incontinent. So here's a third scenario to illustrate continence and expectations for continence. This is a 16-year-old young man with a low lumbar myomeningeal and spastic quadriplegia or cerebral palsy. He is ambulatory. He has cognitive impairment. He has always dribbled urine continuously without the parents ever observing a urinary stream, and he's just always been in a diaper. He's had no urologic evaluation or follow-up since he was 2. The parents felt like he was doing well. They just assumed that he would be incontinent. Then he presented with a kidney infection and was noted to have severe hydronephrosis. So this is a picture of his bladder. So this is quite different from that nice smooth walled bladder that we saw before in the newborn. You can see that the bladder is very irregular here on the left. There's a little outpouching on the left side of the bladder. That's called a diverticulum. And this fuzzy stuff here below the bladder is actually contrast going out into the ducts of the prostate gland. So the pressure is high enough that the urine is not getting out well through the urethra and is causing backflow into the prostate. So this is a pretty high pressure situation. And that was confirmed on Urodynamics. Remember, we had that magic number of 40 centimeters of water. And this child reached 40 centimeters of water when his bladder held about a quarter of what I would expect it to hold for his age. And then the pressures went up from there, and it was only when the pressure got up to 70 that he leaked it all. So this is a pretty dangerous situation. How is bowel control related to urinary control? Well, achieving fecal continence or control of stool is something that's important in the management of children with spina bifida. And fecal continence can occur without urinary continence occurring. We should keep in mind, though, that constipation can aggravate achieving urinary continence, and this is due to secondary contractions in the bladder. It's due to crowding in the pelvis. If there's a lot of stool, it may actually cause urine to come out involuntarily, particularly in a child with an incompetent bladder outlet. Achieving fecal continence in many children with spina bifida is a form of controlled constipation. We let them retain stool, and then we need to evacuate it on a scheduled fashion so that there is not symptomatic constipation or backup of stool. And this can allow them to be clean on a day-to-day basis. So just a word about bowel programs. I'm sure there's going to be other courses for you to look at on Spina Bifida University that will go into depth about bowel management, but this is just my viewpoint on things. So we want to avoid symptomatic constipation because severe dilation of the colon will be counterproductive over the long term and may not be something that can be corrected. We want to achieve continence and predictability in terms of when the bowel movement will occur, because there's a lot of benefit in terms of social continence, social confidence when a child is clean of stool. We want to help them achieve independence and self-care, and so they ultimately need a bowel program that's going to work for them in the long run, something that they can do for themselves. So elements of fecal continence include the sensation in the anus and in the rectal area, the tone of the anal sphincter, the ability of the colon to squeeze the stool through, the child's actual physical mobility, because that helps propel through the stool through the abdomen as well, and desire and commitment on the child's point and also the parents to achieve fecal continence. You should keep in mind that one size does not fit all when we're talking about bowel programs, and there's a lot of fine-tuning that needs to occur. The bowel program must fit the physical profile and the family's preference, meaning that if there's a loose sphincter, we're going to need to do something else than we would in a child who has a tight sphincter. Achieving fecal continence can be more frustrating for some families than achieving urinary continence, and it has a bigger social impact as well. So bowel management in general, I started a program during the toddler years, and during the years before that, we just want to keep the stool moving and avoid symptomatic constipation. At that time, we would recommend beginning with timed toileting after meals, because there's a natural reflex where the stomach tells the colon to push the stool down toward the anus, and so we can take advantage of that if we toilet 20 to 30 minutes after a meal. We want to make sure there's plenty of water in the diet and plenty of dietary fiber. We may consider a fiber supplement and may consider laxatives to help move the stool forward. Techniques for evacuating the stool would include digital stimulation of the sphincter, placement of a suppository, and enema programs. And finally, manual evacuation is effective for some families to clean out the stool on a day-to-day basis, but is not our first line choice for a bowel program. Next question, if my child needs clean intermittent catheterization, when should she learn to do this for herself? Great question. Learning CIC is very important, and I would recommend that at school age, consideration be given to teaching. The goal is independence, and it's the important impact that independence has on socialization in general. There should be a graduated responsibility for catheterization, and it's important to provide support, supervision, and reminders both at home and at school. We have to take in mind the dexterity of the child, how easily they're able to pinch and how easily they can access the perineum or urethra to place the catheter. Consider their flexibility, particularly in the hip and spine region. Consider whether they are able to ambulate into the toilet or whether they're able to transfer themselves to the toilet. The urine smells very strong. Is this another UTI? Urinary tract infections are, or determining whether a urinary tract infection is present or not is a real problem in children who catheterize, because the urinalysis and often the culture will be positive even if there aren't clear-cut symptoms, and the bacteria is coexisting peacefully within the bladder. So bacteria in the urine is nearly universal in individuals with intermittent catheterization. Odor does not mean that there's an infection, it just means that there's bacteria. So we prefer to hold off on any antibiotic therapy. There's little role for treatment of asymptomatic bacteria in the urine, or little role for urinary prophylaxis or a low daily dose of antibiotics. We want to increase the fluid intake. We want to pay special attention to the intermittent catheterization schedule, possibly doing it more often. And if an individual is not performing CIC, then it might be time to consider that. In summary, we want to dilute the pollution. We want to get that bacteria diluted within the bladder and get it out in a timely fashion. So is there bacteria in the urine, or is it a urinary tract infection? There are a couple symptoms that come to mind that we would typically consider a clinically relevant urinary tract infection. One would be a fever without another explanation. One would be increased leakage between catheterization, abdominal or back pain, pain with placement of the catheter, gross hematuria or blood that you can see that persists beyond a few catheterizations, the presence of a stone-forming organism, on culture, such as Klebsiella or Proteus, and an intolerable, persistent odor that we haven't been able to address by increasing hydration and more frequent catheterization. Risk factors for infection would include stasis, or urine sitting around too long within the bladder or within the kidney, hostile bladder dynamics that may drive bacteria into the kidney, and actually constipation increases the risk for infection as well. Hostile bladder dynamics with a urinary tract infection is actually a recipe for kidney damage and something we take very seriously. Stones can also form as a result of bacteria in the urine because bacteria in stasis, or sluggishness of the urine, allow bacteria to grow and form a nidus for stone formation, and some particular bacteria change the nature of the urine so that stones are more likely to occur. And you can see in this radiograph that the whole inside of the kidney is full of stone on both sides, and there are a few stones in the bladder or ureter distally. The importance to preventing stones in individuals with neurogenic bladder is good hydration and intermittent catheterization. Individuals who've had a bladder augmentation where we've surgically increased the size of the bladder are further at risk for stone formation due to mucus collection within the bladder, another nidus for stone formation. So my child was dry on intermittent catheterization, but now he's wet. What's wrong? We have a checklist. The first thing that has to come to mind is neurologic change. But that is not the situation in the vast majority of cases. But we have to give it careful consideration. Common things are common, so we want to consider whether there's a urinary tract infection and treat a positive culture. We want to consider whether there's constipation that can be improved. Look for a stone. We want to consider whether the dose of the medication is optimal for the patient's age, and determine whether the intermittent catheterization technique is adequate. But again, in the back of our mind, we're always wondering if there's a neurologic change. So in terms of neurologic change, we'd be talking about a shunt malfunction, a clinical tethered cord, or other cord change, and we've talked about this already. So clinical tethered cord is a controversial diagnosis, and once the diagnosis is made, if there are urinary or bowel issues as part of the diagnosis, the recovery from this is variable, particularly in terms of the bowel. But we can see an abnormal appearing bladder improve somewhat radiographically, and we hope to see an improvement in the pressures to go along with that radiograph. We want to avoid further deterioration, and that's the primary reason to consider a untethering of the spinal cord, because we want to prevent further changes in the bladder, and we want to prevent future changes in terms of the function of the legs that might occur if we fail to diagnose the condition. Recovery may not be adequate to avoid medical or surgical intervention for the bladder, but again, we want to remove the underlying cause to prevent deterioration. So what if we don't have a clinic or a team nearby? And I know this is a situation for a lot of families with children who have spina bifida. And what I would recommend is that you've heard the minimum surveillance that's required in terms of ultrasound and general health needs. And you now know the changes, clinical changes that will require assessment. You need to be your own advocate. You need to seek consultation when you feel that something is wrong, and you need to make the most of that visit by being very specific about how things are going with management of the bladder and bowels and infections. Why would we ever consider surgical intervention for the bladder? Surgical intervention is necessary when there's a failure of medical management to protect the kidneys, or to provide social continence. So if we haven't been able to do either of these things with intermittent catheterization and anticholinergic medication, then it might be time to consider surgical therapy if you're ready for continence. The other reason is to improve independence and to allow a convenient means to manage the bladder and bowels, and this would be in the form of mitrophanol and MACE. And again, surgical therapy is not going to be prominent in today's presentation. Are there any other options for neurogenic bladder? Sure. First, we have some minimally invasive therapies, and these are technically surgical procedures, but not invasive surgical procedures. So first, if we have a child with persistent symptomatic reflux or urine backing into the kidney after maximal medical management, then we may want to consider deflux, which is a bulking agent, essentially a fancy sugar. It's a dextrin and hyaluronic acid, and it's used to treat vesicoureteral reflux, basically by creating a mound at the opening of the ureter so that urine can no longer go upstream. We want to be sure to treat any hostile bladder dynamics prior to considering this therapy, as otherwise it will fail. We, in select cases, would also use deflux to improve the strength of the bladder outlet in order to help hold urine in when that's the problem. This can be injected in different ways, but it tends to be less durable or not last as well when the catheter is being passed through the urethra. It tends to reduce the bulk of the substance. If we have hostile bladder dynamics while on maximal medical therapy, but you're not interested in considering a more invasive definitive surgical procedure, then we could consider Botox injections. So botulinum toxin A inhibits the release of acetylcholine, a neurotransmitter, from the motor nerve at the neuromuscular junction, so where the nerve joins the bladder. And we can inject Botox through a cystoscope, so with a lighted scope put into the bladder, and we can use a small needle to inject Botox into the bladder wall, or in some cases to inject it into the contracting sphincter. You have to keep in mind that Botox is not FDA approved for management of neurogenic bladder, so this is another off-label use. This is just a picture of the cystoscope. The vessels there are on the back wall of the bladder, and you can see a needle there on the lower part of the image that's getting ready to pierce the bladder wall to deposit some Botox. The problems with Botox is that it only has a temporary effect, and it doesn't work on every individual. Lasts somewhere between 3 to 9 months, and so it requires serial treatments if this was going to be the primary therapy. And the problem with that is not only the repeated treatments and repeated anesthetic, but also this is an expensive substance and many times is not covered by insurance, so it could be problematic for the family. In addition, there can be treatment failures with the initial treatment or with subsequent treatments. And finally, there's a possibility of developing an allergy or sensitivity with repeated injections. So I don't consider this to be a definitive therapy. It's more of a cover-up. Urethral dilation is another treatment that can be entertained, and this is a gradual dilation of the tight urinary sphincter, and this is more commonly performed in infants who have a hostile bladder that we're unable to manage medically. It reduces the leak point pressure, at least temporarily, and improves the compliance or stretchiness of the bladder wall secondarily. It doesn't seem that the tightness of the sphincter is affected in the future in terms of continence, but there is likely fibrosis or scarring that occurs within the sphincter. Overnight catheter drainage is another technique that we're employing more often. This is placing a balloon catheter overnight into the bladder, essentially to let the bladder rest. Then we know that for a defined period of time every day, the bladder pressures are safe throughout. And this may reset a bladder to help it behave more normally or rehabilitate the bladder, but at least we know that we're protecting the kidneys during that period at night. And it may allow us to postpone augmentation or surgery to enlarge the bladder. Less is more in this case, in that if we're leaving it overnight, that's fine, but 24-hour drainage is not recommended for the bladder. So neuromodulation is a technique by which we can stimulate nerves and change how organs function. A technique uses bladder stimulation, and this is a program used for many years with good success here at Children's Memorial. It involved a transurethral stimulation of the bladder with an electrode. And the goals of the therapy were to lower the storage pressures within the bladder and improve sensation of bladder filling for some individuals. And the goal was to avoid bladder augmentation, and was successful in a number of cases. It was a 4 to 6 week treatment daily. Unfortunately, the program is not available currently due to changes in the manufacture and approval of devices within our country, and is only available at a select site in Europe at this time. The InterStim device you may have heard of. It's made by Medtronic, and it's a device that's implanted near the sacral nerve roots and can be used to calm bladders. It is not approved at this time for neurogenic bladder. The Schaub procedure that you may have heard of is a nerve rerouting procedure for reinnervation of the bladder and sphincter. It was championed in China with excellent results, and is being used on an investigational basis here in the United States. The results are promising, but are probably not universally beneficial, or may not be universally beneficial to all individuals with spina bifida, so is being used on a very select basis at this time. And we're anticipating longer follow-up to help guide patient selection. So in summary, individuals are individual. We discussed before my challenge when I look at your child and wonder what the bladder is doing, and face the challenges of each individual bladder. We have to treat all bladders as individuals to get the best results, and it's important to have early and lifelong surveillance in the bladder and the kidneys. And we want to intervene when it's required medically, but also when it's desired by the child or by you to facilitate continence. You have to keep in mind that there's not just one way to manage neurogenic bladder, but we want to stay on target in order to achieve the best results possible. We want to keep a healthy kidney without hydronephrosis in the center of the kidney, and we want to keep a nice smooth wall bladder with low storage pressures. Surgical therapy, again, is not going to be discussed in this talk, but in a subsequent session, and I don't think that we have to uniformly consider surgical therapy a failure of medical management. Medical management is not adequate for all individuals, and consideration needs to be given to surgery in those cases, even with our best efforts. Thank you very much.
Thank you for attending this session. Because meeting your needs is important to us, we need your feedback on this presentation. Please take a few moments to complete our evaluation, which can be located by clicking on the presenter's name located to the left on your screen. It will only take a few clicks of your mouse to provide us information to make the SBU experience better for you and others. If you have any questions relating to SBU, please contact us at sbu@sbaa.org.